Hey everyone, and welcome back to the Gaining Health Podcast. I'm your host, Karli Burridge, and I'm very excited to be joined today by Chris and Cristy Gallagher. Just to give you a little bit of an introduction, Cristy has spent over 20 years working in Washington, D.C. on health, human services, and education policy. And she is the Senior Center Administrator of the Redstone Center of the Milken Institute of Public Health with George Washington University. And her current work is centered on the Stop Obesity Alliance, which is a part of the Redstone Center. And the Stop Obesity Alliance stands for the Strategies to Overcome and Prevent Obesity and is made up of a diverse group of businesses, consumers, government, advocacy, and health organizations dedicated to reversing the obesity epidemic in the United States. So, drawing on the strengths of the collaborative, STOP conducts research, makes policy recommendations, and develops hands-on tools for providers, advocacy groups, policymakers, and consumers. And Chris Gallagher is the Obesity Action Coalition's policy consultant and also serves on the Access to Care Committee for the OAC. And he has had more than 30 years of legislative and lobbying experience where he has specialized in healthcare, tax, and education issues. He currently manages several healthcare issues while working with different organizations, including being the lobbyist for the Obesity Medicine Association, the American Society of Metabolic and Bariatric Surgery, and the Obesity Society. So I am so excited to have you both on the podcast today. Thank you so much for joining me.
Thank you for having us.
Yeah. So I have to ask you guys, how often does it happen that people think that you're the same person?
I think this is the first time we've actually been seen on camera together.
Not really, but it has happened before, including when people, start into a new job that might be something that we both sit on a committee for, or both the organization's a member of the Stop Obesity Alliance, and they're sort of new. And for a while, they begin to think that. So I know that Tony from the Obesity Society, when he first started in the executive director role at TOS, thought that Chris and Cristy were just the same person. So
I know. And I'm embarrassed to say I actually was one of those people. I did not realize that you were two different people because you're both so involved and your name comes up all the time with this advocacy stuff. So I definitely knew the name. I just thought you were the same person. It wasn't until, Cristy, I met you in person earlier this year at the AAPA Leadership and Advocacy Summit that I realized you were two different people.
Yep, that
But
would
you
have
guys,
been if the wrong person showed up or something.
I know, right? But you both are so involved. You do so much. So how did the amazing advocacy power couple, you two, how did you all meet? I know, I like this term for you guys, advocacy power couple.
Well, we met playing softball on the mall here in Washington, D.C. So
Okay.
we ended up on the same team the summer of 1997 or 98. I think 98. And
Even remember?
and our softball team, the name was the LSD, which stood for the Last Surviving Democrats. So it was the last members of the North Carolina congressional delegation that were Democrats. And then I sort of just landed on the team, a friend of a friend ended up there. So Chris was a really good pitcher.
No.
No.
He's a foul ball hitter.
I was a catcher.
So I fouled off about 16 balls that Cristy had to chase down. And so that's kind of how we initially met. And then we took, I think it was 7 or 8 long weeks until we got engaged.
It was very fast.
Wow. 7 or 8 long weeks. Wow.
And we were engaged by December.
Bought a house together in November.
Yep. So what's really interesting is there were 3 other couples from that team that got married as well and are still married and live in the DC area. So if you're young and you're looking for a way to meet other people, playing softball or kickball or whatever on the mall is a great way to do it.
And there's longevity from our studies we've conducted.
Yeah.
From your studies. Yes, that's awesome. No, that's funny. That's how my husband and I met too. We met playing volleyball in college. So sports, brings people together. You guys had the interesting connection of also having the political aspect of it. So it's like, two things. But yeah, my husband and I met playing volleyball in college, and we actually have, let's see, let me count them. Four other couples who also, so the girls who are on my team and the guys who are on my husband's team, who also got married and who are all still married as well. So this is apparently is a recipe for success. This is awesome.
There you go.
The family that plays together stays together.
Right? Yeah. And now it's great because now our kids are playing volleyball too. So it's fun. So it's something that we can all do as a family. Do you guys ever still play softball these days, or do your kids play at all?
Nope. Nope.
No, no.
Nope. Truly, it was only a way to go and have fun with young people. For me, I was not a good player. So,
Sure
But
you.
now you guys do advocacy together.
right.
So tell me, how did you both get involved with obesity advocacy, and how did all of this work start for you?
I'm going to go first.
Yeah.
So, my advocacy career started working in the surgical community, and one of my jobs was about a decade stint at the American College of Surgeons back in the mid 90s, where part of my job was to take smaller surgical specialty societies around Capitol Hill, visiting with the leadership on the healthcare committees and such. And one of those small groups at the time was the American Society of Bariatric Surgery, and I ended up taking the leadership of ASBS at the time up around the hill in the mid 90s. And when 2007 came and I opened up my own company, I reached out to folks like Georgianne Mallory, who is the executive director of ASMBS, and said, this time Metabolic and Bariatric Surgery Association. And I said, do you need a lobbyist? She said, yes, we do. In fact, our lobbyist just left. And from there, it was really a cascade of dominoes. I started also working with Joe Naglowski at the same time, who was the president of the Obesity Action Coalition. So basically, OAC became my first client, ASMBS shortly after that. And then I remember Joe saying, oh, you need to talk to this guy, Ted Kyle, who's the chairman of the Obesity Society's advocacy committee, and did that. And lo and behold, TOS became a client. And then OMA kind of completed the puzzle of covering patient and medical and surgical intervention for obesity.
Wow, that's amazing. And what a difference. I mean, I'm sure, going back to 2007, like what was that like, starting in those earlier days of metabolic and bariatric surgery, because they've had so much success with getting coverage. And I'm sure that's in large part due to your efforts as well.
Well, I think the ASMBS is full of dedicated surgeons, advocates, and bariatric nurse coordinators, nurse practitioners, PAs. They have really been a force for advocacy, and I think when I started advocating with the bariatric surgeons, it was interesting because a lot of people, you were still having that conversation and disagreement as is obesity a disease, and that would be kind of the first 10 minutes of our hill visits. And the nice thing through all the education I've been doing with advocates at OAC, ASMBS, TOS, OMA, and such, we have really turned the corner on that. So when we go into Capitol Hill offices these days, it's fairly well agreed that obesity is a disease. At least that's what people will tell you, and they will agree with
Mhm.
you. We're still working on the part where, oh, it deserves treatment too.
Right.
Everyone is, it was always prevention, prevention. Then it was prevention, prevention, and a little bit of treatment. Now I think we're swinging back to where it's going to be both prevention and treatment for obesity, and we've seen great steps in that forward from CDC, who recently put out their press release on obesity rates, showing nearly 42% of Americans are affected by obesity. I think this was the first time that CDC came out and said, not only do we need prevention, but we also need treatment of obesity. So we are changing minds. So it has come a long way.
Yeah, that's amazing. And recognizing that treatment doesn't is not the same as prevention. So, the lifestyle factors, yes, very important, but that's not the end all be all. When we're talking about treatment of obesity, we're talking about what else? What else would you guys consider? And I think this is part of what you worked on too, right? As far as creating the comprehensive obesity benefit. Can you tell us a little bit about that and what that includes? Cristy, maybe you want to tell us about that?
Sure. So I started at the Stop Obesity Alliance at George Washington University about 11 years ago, and did get my foot in the door there through Chris's connection with his clients. He had found that the director of Stop at the time, Cristy Ferguson, was looking for someone to come in and work with her on her obesity work, and so I stepped into that role in 2011, 2012. And one of the first things that we did when I was there was bring together experts in the field, as well as pharmaceutical companies who had some treatments that they were in trial and ready for approval on, as well as the FDA. And I think that was another big turning point. It was right before the AMA declared obesity as a disease, but we were able to bring the FDA into the room and explain to them that these medications were different than the past medications that were considered sort of weight loss or diet drugs. That these should be considered obesity medications. And shortly after those roundtable meetings, the FDA did begin to approve these, new class of drugs, new medications, and we really saw some success. And so from there, some of the work that I started doing on Stop was looking at the coverage of obesity treatments. So we began to look at Medicaid coverage as well as state employee health plan coverage. And we did that survey sort of every year or every other year for a while. And as one of our research assistants, I have the pleasure of being able to hire students who are in the School of Public Health to do a lot of this research. We had one who really dug deep into the Medicaid, coverage, and one of the things that she kept finding was that, to search in a health plan for coverage of what the payer was going to cover was tedious because it listed so many different names. There was never just a one place where you could find obesity coverage. You had to search diet, you had to search weight loss, you had to search obesity, all of that. And so we went from that sort of knowledge to develop a standard of care, which we published after bringing groups together to talk about that. And then went from beyond that to develop this comprehensive obesity benefit. And so this is what we would say is evidence-based treatment that should be provided by payers to patients. And therefore, providers don't have to think about whether something's covered or not. They can use the gamut of all the different treatments that are available, everything from lifestyle, IBT to pharmaceuticals to surgery. And that way the patient can use sort of, where they are, meet them where they need to be for treatment.
Absolutely. And that's so important. I think, that just cannot be overemphasized that whatever the patient needs, they should have access to it, right? And this is something that I've also been really passionate about. I started out, well, before I was a PA, I was in clinical exercise physiology and really interested in lifestyle and disease prevention and that side of it. And then as a PA, landed in a job in bariatric surgery. And that was really my introduction to obesity because honestly, like we don't get much obesity education at all in our medical training. And so I had no idea about the complexities and the hormones and everything. So and then after working in bariatric surgery for a little bit, I thought, well, how can we take what we know from bariatric surgery and how can we use that to treat somebody medically? Because there were so many people who perhaps didn't need surgery yet, weren't at that point, or had surgery and needed additional help with this chronic disease. So, yeah, I'm such an advocate for people being able to have coverage for wherever they are in their journey and whatever their needs are, right? So, where are we now as a country as far as states covering this comprehensive benefit?
Well, STOP has done our most recent survey on state employee health plans. And so this was research that we did in 2020 and 2021. And we did find that in some ways states were covering more, but in other ways, states had actually dropped some coverage. So we were shocked to find, I believe it was 9 states that had dropped coverage for anti-obesity medications. And so that was, sort of another eye-opening sort of experience. And one of the things that STOP is able to do is we do the research and then we put it out there. And then the groups that Chris represents are able to then use that research and then go out and advocate. So you want to talk a little bit about some of the states that have added coverage since then?
Yeah, it's been a fun battle, as it always is these last couple of years, but we've had some great success in terms of state employee coverage. And it's interesting, we've attacked it both legislatively and kind of behind the scenes, the back door through the regulatory approach. And I'll give you one example of Pennsylvania, where for the last 5 or 6 years, we have been working with Representative Oberlander, a Republican in Pennsylvania in the House, who I think is the majority whip in the House, who introduced a bill to get AOM coverage for Medicaid recipients. And that has passed the House a number of times in Pennsylvania. We have now made tremendous progress in the Senate. It just got passed out of the Senate Health Committee. But at the same time, we were having discussions with the Pharmacy and Therapeutics Committee in Pennsylvania, the P&T Committee, if you will. And one of our great advocates, Verlyn Warrington, started working with the P&T Committee and educating them about AOMs and the benefits of having comprehensive coverage. And as a result of her efforts and other advocates like Vicki March and Ted Kyle and Sunil Daniel in Pennsylvania, the P&T Committee has now announced that they are going to be covering AOMs beginning in 2023, and in fact have invited Dr. Verlyn Warrington to be a member of the P&T Committee in 2023. And we're seeing that, in Colorado. Colorado is adding coverage for state employees. And again, that was kind of through the Pharmacy and Therapeutics Committee. And so it's working it on both levels, but I think we're starting to turn the tide, and where we hope to see no other states drop coverage, but instead increase coverage. And I think the big catalyst will also be 2 things: the Office of Personnel Management that recently announced that they're requiring all health plans for federal employees to cover anti-obesity medications. And I'll let Cristy fill you in a little bit more about that. And then the AMA just came out saying that they're going to join the fray on working with state medical societies, specialty societies, to ensure there's comprehensive coverage from counseling to drugs to surgery for obesity. And that is something that just came out of the recent meeting they're having right now. So that's going to be helpful. But Cristy, if you want to talk about OPM, since you were integral in.
Yeah, so that's another big success that we saw this year, which was working with the Office of Personnel Management, which provides guidance to all the federal employee health plans, so the FEHPs, on the benefits for employees. And when you think about federal employees, this is one of the largest employers in the entire United States. And the fact that they have now provided guidance that pretty much mirrors the comprehensive obesity benefit as far as what should be covered for counseling, for anti-obesity medications and surgery. It's, really a great advance that we have made. And the fact that they did that, even knowing that this could be a cost driver for them, they looked at the numbers. They said, it shouldn't be limited because of the cost of the medications, because obesity is a disease and it should be treated like any other disease. We wouldn't limit what we provided for treatment if it was cancer. So we shouldn't do that for obesity. So that's, a big win that we've seen this year as well.
And I think the important thing to note about that wasn't overnight. I think back in 2013, OAC President Joe Naglowski, working with folks like Bill Dietz and Donna Ryan and other leaders in TOS, began this conversation with OPM. And it was interesting. In 2014, OPM sent out guidance to its carriers saying, hey, we understand that some of the plans are excluding coverage for obesity treatments like drugs, FDA approved drugs, based on the view that the plan believes obesity to be a lifestyle condition, or that treatment is cosmetic in nature. That is no longer permissible. And basically, if you are going to deny coverage, you have to provide a clinical rationale. So when that hit the papers in 2014, everyone was, there was one headline like, feds are going to open up, the floodgates for weight loss treatments. And it was interesting that only a handful of plans enacted coverage for obesity medication. So the gentle nudge did not work. And we found with obesity, you really have to, I don't want to say mandate, but, spell out requirements for plans that, as Cristy said, it's a chronic disease. And you wouldn't do that to any other chronic disease. Decide to limit coverage or make patients jump through insane hoops of like, oh, you need to prove you're on a weight loss program for 3 to 6 months before we're going to let you even attempt this taking this medication, or you only get one shot a lifetime on an anti-obesity medication, and if you fail, well, that would be crazy. You wouldn't do that with cholesterol. I mean, I have my dad's cholesterol, so I've gone through 2 or 3 different drugs because the first one, made my joints and muscles hurt really bad. And, through trial and error, we found the best medication. And the same should be true for obesity.
Absolutely. Yeah. And that's where so much of the bias and stigma comes into play, right? And would you guys agree? Is that one of the biggest barriers, is just this idea that it's a lifestyle choice, and this lack of recognition of the biology behind it, and why obesity is a disease? Or where do you guys think is the biggest hang up? Because we have been doing this for a long time, and you guys have made amazing progress. But like you said, it's the gentle nudge doesn't seem to be working. It seems like we really do have to be more forceful with this, because it's just so hard to overcome some of the weight bias and stigma. Is that kind of what you guys
I
have
mean,
found too? Is that the hardest part?
I, in 25 years of being in the obesity space, I think the most mind blowing year I had was COVID in 2020, because we had done so much education about the need for obesity treatment. So many people are accepting of the, discussion that obesity is a chronic disease. And yet when COVID hit and it was disproportionately affecting individuals with obesity and overweight, as a lobbyist for the obesity community, I was like, while this is horrible, this is a perfect opportunity to say to policymakers, look at all the footage of people in the ERs and in hospitals. They are all affected by obesity. And the numbers coming out of CDC prove that obesity was a significant risk factor for bad things happening to you if you contracted COVID. And yet we, still couldn't get policymakers to move. It was very frustrating because it's always been, obesity. Yes, Chris, it's a huge problem, but it's not going to kill you in 10 or 15, days. It's going to kill you in 10 or 15 years. And I'm like, no, it can kill you in 10 or 15 days with COVID. And we've seen similar things with other respiratory diseases. So it's still out there. And I think, people will tell you to your face, oh, we agree obesity is a disease, but there's still that kind of hidden bias, I think. Because if there wasn't, we should be making traction on this. We get nearly 200 co-sponsors on the Treat and Reduce Obesity Act, which is in its 10th year now. Basically, its 5th Congress. And it's bipartisan in nature. It's always like a 60-40 split. It's always well supported, no matter who controls Congress, Republicans or Democrats. So people say, oh, if the Republicans take the House next year, what does that mean for TROA? It doesn't mean anything. We'll still have the same support. What we need, though, is the committees of jurisdiction and the leadership to say this is a priority for us. And that's something we continue to work on.
Yeah. And so, for people who are not familiar with TROA, can you explain a little bit what TROA is and why it's so important that we get this passed and that people and healthcare providers and anybody who hears about TROA goes and supports it?
Sure. So TROA is shorthand for the Treat and Reduce Obesity Act. It is currently in Congress. It's been championed by uh, Senator Tom Carper from Delaware and Senator Bill Cassidy from Louisiana. On the House side, Ron Kind, who is retiring this year as the lead Democrat on it, and Brad Wenstrup is the lead Republican. But this legislation addresses two coverage roadblocks in Medicare. First is that when Medicare program adopted coverage for intensive behavioral therapy services, they did it in a very limiting way, basically saying that only primary care providers, nurse practitioners, PAs can provide this service and directly bill Medicare for it. So it didn't allow other folks like registered dietitian nutritionists or clinical psychologists, obesity medicine specialists, technically to provide this service and directly bill Medicare. So that's the first part of the bill would allow the patient to first see their primary care provider, but then they could be then referred to, say, an RDN or a psychologist or a community health program who would take over that care while still reporting back to the primary care provider so that everyone's kept in the loop. And I think that is a crucial part. The second deals with the fact that when the Medicare Part D prescription program was created in 2003, 2004, they relied on a list of services that was established in 1990, so over 30 years ago. That was a list of things that state Medicaid directors could choose to cover or not cover with their particular state Medicaid program. And these things included, I think, smoking cessation drugs, uh, drugs for weight loss or for weight gain, over the counter cough medicines. And when Congress enacted the Part D program, they said, oh, anything on that list, we're just not going to cover. And it's been very frustrating because in 1990, we know a heck of a lot more about obesity than we did in 1990. So we are constantly up against the Part D prohibition on drugs for weight loss or for weight gain. And we have had so many educational efforts with CMS, the Centers for Medicare and Medicaid Services, about this. We've tried to fix it legislatively through TROA. We've also talked to the administration and CMS saying, can't you just use your administrative authority to lift the prohibition? Because they have done it in the past. Again, it's no, excluded our drugs for weight loss or for weight gain. And in the past, CMS had said we will allow drugs for weight gain in the case of AIDS wasting. And they said, well, that's, we're looking at a chronic disease here, a chronic condition, and that's okay. And we kind of argued, what's the difference? It's the same thing with obesity in reverse.
Right. And in the 1990s, obesity was not recognized as a disease by the AMA, and now it is. So, and they're not weight loss drugs, right? They're obesity or anti-obesity medications. So yeah, I can understand how for you that's probably beating your head against the wall, like hello.
I mean,
But
obesity has been, well, I would say obesity has been recognized as a disease by the NIH going back to the 80s and 90s.
right.
And the federal government, IRS, Social Security, have deemed it a disease for disability and tax reporting requirements in the early 2000s. And 2013, again, when AMA recognized obesity as a disease. The interesting thing about that was that should have ended the discussion, but yet AMA had to come back the next year and say, oh, obesity is a disease and people should get access to treatment, like
Right.
counseling, drugs, and surgery. Like, why do you even have to say that? And then 2 years
Right.
later, they come back and say, oh, and there's still roadblocks and we're going to help break them down. So it is amazing that one simple statement should solve everything. Obesity is a chronic disease, and therefore, with that comes all the benefits associated with that recognition.
Right, right. And so obviously you both are doing so much work to advocate for people with obesity so that they can get coverage for the treatment that they need and deserve. Cristy, what do you think healthcare providers can do, or even anybody listening to this podcast can do to advocate for obesity coverage at their state level, at their local level? What are some resources? I know you all have some great resources on the Stop Obesity Alliance website. Can you share what some of those are?
Sure. Well, I'll first start with some of the resources that we have. If there are providers listening that want to learn more about how to start that conversation with their patient, one of the things that we did at the Stop Obesity Alliance was put together a guide called the Why Wait Guide, and it really walks through, what are the steps that a provider should go through when a patient is in their office and they want to start the conversation about weight, because a lot of providers don't know how to do that, and so they just don't do it. And then we also worked with a lot of the primary care associations, including the AAPA and the family physicians, the nurse practitioners, a lot of the organizations, to come up with another guide called the Weight Can't Wait Guide. And that guide also starts with, when a patient is in your office and you have 6 to 12 minutes with them, what are some of the steps that you can take if you recognize on their chart, looking at gathering the data on who they are, and you can say, would you like to talk about your weight? Is this a good time to talk about your weight? And then what to do if they say yes, or what they do if they say no. So we have some of those resources. We also have a lot of the resources about coverage. So if they wanted to go to the website and look at their own state, they could see whether their state employee health plan covers, therapy, anti-obesity medications, and surgery. And if they don't, they would need to do the research in their own state. And this is where Chris and his work steps in. But they can see whether it's the health association, the insurance commissioner, whoever it is who makes those decisions on what is covered by the state employee health plan. Often it's the legislature as well, and then start advocating. So there are different teams at the state level. I would certainly encourage all providers to go to their own sort of association and see what they have on their website. And if they don't have anything, reach out to us, and we'd be happy to put them in touch with the right people in their own state.
And a lot of
Awesome.
times we do kind of template resolutions for groups who want to say go to their state medical society and say we don't have policy on obesity, and getting that on the books will help your association kind of join you in your advocacy.
That's awesome. So yeah, you guys are really there to support people on the ground level. You guys are doing the work. So anybody who is passionate about this, and we all should be passionate about this, can reach out to you too. Are there any specific websites or places? I'll put it all in the show notes, but anywhere specific that you would send people to find out more about this?
I would say, I mean, for the folks I deal with mostly on the patient level, you've got the Obesity Action Coalition, and their website is phenomenal
Mhm.
on educational resources on kind of what is obesity treatment, and their website will walk you through counseling and pharmacotherapy, all how the drugs work, mechanisms of action, bariatric surgery, and also how to initiate the conversation with your provider. Cristy and Stop have done a great job on the provider side helping them have that conversation with the patient, but that's not going to occur until the patient asks for it in many cases. So, the OAC's Your Weight Matters program is kind of a challenge to have that conversation, initiate the conversation with your provider on obesity. So I think NOAC has some great advocacy resources in terms of their Legislative Action Center, where we have alerts both on the federal and the state level. And simply going in there and entering your name, address, and zip code, hit a button, you'll get letters to your local rep and both senators. And you will have become an advocate. And more importantly, we can track who has reached out in various districts. So if I have a meeting with a representative and their staff says, oh, we haven't heard from anyone back in the district, I can say, oh, yeah, here's 8 people, here are their hometowns. And I've copied them on this email to let them know that I'm talking with you, and they've already reached out to the representative. And that does a great deal in terms of shutting down that somewhat BS argument for not co-sponsoring our legislation.
Yeah, that's a great tip, and it is so fast and easy because I think sometimes people get overwhelmed at the idea of getting involved with advocacy, but the OIC has made it so easy. I've done it. You just go on there, you just click on something, fill in your name. It takes less than a minute, and it's so important. So, thank you so much for sharing that resource.
I would also say OMA, we've developed, the advocacy committee has put together an advocacy toolkit, which is on the OMA's website for OMA members to utilize, kind of walks them through how to reach out to their state medical board, their state medical society, reach out to governors, state insurance commissioners. So it's got a great deal of links. And ASMBS has their access to care toolkit that is on their website, kind of similar resources. It's fun to have one guy who works for everybody because you can kind of repurpose stuff. I won't say that out loud.
Yes.
And TOSS is doing a great deal of work with their advocacy and policy committee, looking and being more proactive on legislation and kind of developing regional networks and such as well.
Another great resource is the Obesity Care Week. So the first week of March every year is Obesity Care Week. And if you want to go to one place where you can reach all these different associations and get involved and become a good advocate during that week, that's a great website that you could include.
Awesome. Well, thank you both so much. I'll make sure to put all of those websites in the show notes. And just thank you so much for everything that you do for people affected by obesity, their families, for the field of obesity medicine. You guys are incredible. So thank you so much for all you do. And thank you so much for being on the podcast. This was super fun. Thank you so much for joining us on the Gaining Health podcast. Don't forget to review and subscribe, and if you really liked it, consider supporting us on Patreon. Lastly, if you need resources and tools to help you start an obesity management program, be sure to check out gaininghealth.com. Thank you, and we'll see you next time on the Gaining Health podcast.